Okay, we're going to pick up Obstetrical and Gynecological Emergencies Part 2, starting with the neonate. Now, the neonate is a definition given to the newborn. So it's from birth to the first, some would say 24 hours, some would say 24 days or the first month. But the neonate, here we're talking about the delivery of the baby. As soon as the baby is born, they're considered the neonate, and you're going to assess them immediately. You want to note their what they call an APGAR score. The APGAR score does not guide resuscitation efforts. If the baby is, like any patient we assess, unresponsive, not breathing or only gasping, or even has a heart rate less than 60, they're going to need chest compressions and CPR. The APGAR score does give us an idea of how well the baby's doing. It's based on the baby's appearance, the pulse rate, their ability to grimace, how actively they're moving their arms and legs, and what their respiratory effort is like. Each one of those appearance, pulse, grimace, activity, and respiratory are given a score of a certain number of points, and you're supposed to be able to give the baby an APGAR score at birth and at 5 minutes after birth. What's far more important is that you're just noting the baby's appearance and whether or not they're having a hard time breathing, whether or not they have a pulse, whether or not they're crying actively, their skin is moving, or their extremities are moving, and their skin temperature and color is good. It may be necessary to stimulate a newborn to take a breath. Um, One thing I dislike about this particular picture is the fact that newborns can become extremely hypothermic quickly. Um, they The ability to shiver is not there. They have very little energy stores at birth. Their body surface area to mass is skewed a little bit. They have a whole lot of body surface area and not a lot of mass. As a result, that body surface can dissipate heat quickly. So we need to dry them off when they're initially born, and then immediately after looking at them, assess their immediately cover them up to keep them warm. You might have to slap them on the bottom of the feet, rub the lower part of the back in order to get them to take that breath. Now, we're doing this because we've already suctioned the nose and mouth at the perineum, and we know that there's not any mucus or meconium in those airways. So keeping the baby warm is a really high priority. Dry the baby, discard the wet blankets, wrap the baby in warm, dry blankets, and make sure to cover the head with a little stocking cap or a towel or something. And then encourage the baby to breathe, cry, that sort of stuff by, again, rubbing the small of their back or tapping them on the bottom of the feet. Now, when you would cut the umbilical cord would include times like if the umbilical cord was wrapped around the baby's neck and couldn't be slipped over the baby's head, or if the attachment to the placenta impedes resuscitation, or if the attachment to the placenta interferes with the urgent need to transport the mother or the baby, or if your protocol requires you to cut the umbilical cord. The umbilical cord has a pulse of its own and will pulsate, pumping blood from the placenta, from the mother through the placenta into the baby, as long as that placenta is attached to the uterine wall. And once the placenta is delivered, the pulsation will stop. And at that point, if not already done, it would be appropriate to cut the cord. Just make sure to clamp the cord with the two clamps about 6 inches away from the baby's belly, leaving them plenty of cord if they need to get in there and access the artery or two veins that lie inside the cord. Keep the baby warm. Use your sterile clamps. It says, oh, they're going one clamp 10 inches from the baby, second clamp about 7 inches from the baby. So I said 6, they say 7. tomato, tomato. We just want to make sure that we leave enough room to access the umbilical artery and the umbilical veins if they have to. Cut the cord between the clamps using surgical scissors. Be careful when moving the baby so no trauma is brought to the clamp cord. And then place the baby on the mother's abdomen. Maybe one of the first things you might do after cutting the umbilical cord. If the mother is going to breastfeed, there is nothing wrong with having the mother put the baby to mother's breast. The baby suckling the breast will release a hormone that will cause the uterus to continue to contract, which will help control hemorrhage postpartum, post-delivery of the baby. There should be at least somewhere around 500 milliliters of blood loss during a birth. So losing blood is something that will occur. Remember that the mother's blood volume has increased by 45%. So losing that 500 mils is, shouldn't put the mother in shock. But blood loss can be more significant than that. And if so, you might have concerns with that. Here they're showing you to place the first clamp 7 inches away from the baby, the second clamp 10 inches away from the baby, so there's 3 inches between the two clamps, and then cut it. Provide warmth, assess the ABCs. If the baby's airway isn't open, open it. If it needs maintain it. If it needs suction, suction it. And remember, those airways are so tiny on newborns that it takes little or no mucus or saliva or anything like that to plug their airway. So it's really important that we keep that airway clear, open, and maintainable. If the breathing is shallow or slow or gasping, then you want to provide positive pressure ventilation at a rate of 40 to 60 breaths a minute. We often teach people in newborn resuscitation courses that you get a good seal with a mask, and you just say to yourself, bag the baby, 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 bag the baby. So that gets you about 60 breaths a minute. You want to assess the infant's heart rate while you're doing that as well. If the heart rate is less than 100, because infants' heart rate should be around 150, 160. So if it's less than 100, you want to provide positive pressure ventilations. If the heart rate's less than 60, you want to begin chest compressions at a rate of 120 a minute. If breathing is adequate and the pulse is greater than 100, then we're in pretty good shape. So we use an inverted pyramid of resuscitation when resuscitating neonates. It begins with drying, warming, positioning, suctioning, tactile stimulation to get them to breathe. You may have to administer oxygen by blow-by. You may have to assist their ventilations with a bag mask. You may have to do chest compressions. If those things don't bring the baby around, there may be a need for an advanced airway. And finally, one of the last things that we consider is medications. We've all been taught how to do CPR on an infant in our basic life support courses. When we have that team of healthcare providers, we're going to do the 2 thumbs encircling chest technique. And we're going to not only push with our thumbs, we're going to squeeze with our fingers. And in doing so, we actually move more blood than with just 2 fingers on the sternum. So once the baby has been delivered, some of the care that needs to occur to both the mother and the baby includes caring for the mother first. When the baby's born, you now have 2 patients. So your partner may have to care for the mother or the baby, or vice versa. But the mother's at risk of serious bleeding, infection, and emboli postpartum. So it's really important that if she's bleeding seriously, that we look at ways that we can control that hemorrhage. Delivering the placenta is something that should occur naturally within 20 minutes. If it doesn't, you need to transport to the hospital. You're going to have to be there to help assist with the delivery of the placenta. No pulling on the umbilical cord to speed that process up. Just be there to collect the placenta and bag it up. and bring it in so that they can make sure that it is all of it is present, and they will do some lab tests on it as well. If they're bleeding, if the woman is bleeding heavily out of the vagina, you're going to need to control vaginal bleeding, and there's two ways that we would do that. First is to place a sanitary napkin or an ABD pad at the vaginal opening, understanding that there may be some tear from the episiotomy that occurred when the perineum tears if the baby's large. And the postpartum hemorrhage that occurs when the placenta detaches itself from the uterine wall. Again, if the bleeding is significant, we're not going to pack anything in the vagina to help control the bleeding. We're just going to place that pad over the vaginal opening, and then you can massage the fundus of the uterus, which would be the very top part of the uterus, causing it to contract. That is not a fun thing for the mother to go through, but it may be necessary if you need to control hemorrhage. The other thing, again, that you can do is to put the baby to breast if the mother's going to breastfeed. That will release hormones, Pitocin, that will cause the uterine to contract and may help control hemorrhage. The placenta, the umbilical cord, the amniotic sac membranes, and the tissue lining the uterus is what they call afterbirth. And the placenta delivery starts with labor pains, just like the delivery of the baby. And they're saying it may take up to 30 minutes or longer, but that you do begin transport within 20 minutes if it's not delivered. And here is that picture of helping the mother deliver the placenta. Here's another picture of how to control hemorrhage. They put the baby to breast, and they're massaging the uterus over the fundus in order to help control vaginal bleeding. Place a sanitary napkin over the mother's vaginal opening. We don't place anything in the vagina. Have the mother lower her legs and keep but not squeeze them together. And then again, massaging the uterus will help it contract, which helps control bleeding. And again, if the mother is going to nurse, encourage her to do so, which will cause the release of that hormone that will cause the uterine to contract as well. You want to get their vital signs frequently, especially if there's ongoing blood loss, to see if there's any evidence of shock. And your acts of kindness will be appreciated and remembered. Wipe the mother's face and hands with a washcloth, replace blood-soaked sheets and blankets, kind of clean the area up, and clean the baby up as well. Again, I had mentioned about 500 mils is considered to be normal blood loss, and the acts of kindness to the mother, again, are to she's been sweating, working hard, so getting her into a position of comfort, putting some dry, clean linen under her, wiping her forehead off, those sort of things. Now, there are times where childbirth is not precipitous, where childbirth is complicated, and we're going to talk about a few of those. Some complications associated with delivery. One is the cord around the neck, and in that particular situation, if you can slip the cord off the neck, then that would prevent, as the baby being delivered, stretching and perhaps even tearing the umbilical cord, or choking the baby as the cord is around the neck. If you can't slip the cord up around the neck, you're going to need to clamp it and cut it. An unbroken amniotic sac, and we talked about how to fix that by breaking the membrane with your fingers. And then you may have infants initially upon birth who don't take that first breath and may need some encouragement, tapping on the bottom of the feet, rubbing the small of their back in order to get them to take that first breath. Now, breech presentation is probably going to be your most common abnormal delivery. In a breech presentation, the buttocks or both legs are delivered first instead of the head. The risk of birth trauma to the baby is high in this particular case. Meconium staining often occurs because the baby may have a bowel movement in the vagina, and then as the rest of the baby is being delivered, the baby is dragging itself through that meconium. The other issue is that if the shoulders and chest come out of the mother's vagina and the head is still in there and hasn't delivered yet, the baby's going to want to take a breath. So, that can really be a challenge if the baby takes a breath uh, um, while the head is still in the vaginal opening. Now, here's an example of a breech presentation where we've got the buttocks and the legs coming out first. And again, trauma to the baby could occur because delivering that head is going to be a challenge. If you've got a limb of an infant that protrudes from the vagina, it's most commonly going to be a foot when the baby's in a breech position. Limb presentation requires a emergency C-section. So you need to alert the receiving facility you have a limb presentation and that you are running hot back to their scene. So here certainly is an example of a limb presentation with a foot first or arm first, in which case the only way to get the baby out is going to be an emergency C-section. Prolapsed umbilical cord occurs when the umbilical cord presents first, and the umbilical cord becomes squeezed between the vaginal wall and the baby's head, which is going to cut the oxygen supply off to the baby. So that is a life-threatening condition and is one of the very few and rare instances that you would place your hand in the vagina of a mother who's trying to deliver this baby with a prolapsed umbilical cord. So what you see occurring here is you want to elevate the mother's hip, give her lots of oxygen. You want to keep the baby's head away from the cord, so that may require you to place your hands in the vagina and lift the baby's head up off the cord. You're going to know that you're successful because the umbilical cord has a pulse of its own. And if the baby is putting a lot of pressure on that umbilical cord, it won't have a pulse. Multips or multiple births, if you've only got one OB kit and you're delivering twins or triplets, you're going to need some additional resources. Mothers may have one placenta for their multiple births, or they may have multiple placentas. So what's important here is that once the very first baby is born, you clamp and tie the cord, and then the second baby may be born, particularly if both babies share the same placenta, and you're going to clamp and tie that cord on the second baby. And then you're going to have to keep both those babies warm, do all the stuff that we talked about, drying, tactile stimulation, covering warm. If either of them have a heart rate less than 100, you're going to give oxygen. If either of them have a heart rate less than 60, you're going to do CPR with the oxygen. And so you can see here, if I've got multips, I've got multiple births. If I've got two babies and one mom, I now have three patients. So plan accordingly, especially if you know that you're going to deliver this child in the home or children in the home. You may have to call for backup. Premature birth, typically babies born prior to 24 weeks gestation are not viable. I think some will take that down as far as 20. So if a baby is born, before or when gestation is less than 20 or 24 weeks, then it is not likely that the baby is going to survive. If the baby is born prematurely, you're going to keep them warm. You're going to do everything that we've been taught to do concerning resuscitation. Make sure their airway is clear. Typically, if they're premature, their lungs are underdeveloped. They lack surfactant, so there's usually lots of issues with fluid in their lungs, and it's difficult to ventilate them. But you want to provide ventilations. If their heart rate's less than 60, you want to incorporate chest compressions in with that as well. Watch the umbilical cord for bleeding, because if the umbilical cord is still attached to the baby and there's any sort of bleeding, the baby is going to lose blood as well. Avoid contaminating the premature baby. Their immune system is going to be extremely suppressed, and any potential contamination could lead to illness or death. Call ahead to the emergency department to let them know that you're coming. Now, meconium, meconium is the baby's first bowel movement, and it stains the amniotic fluid a greenish or brownish yellow in color. You don't want to stimulate the infant before you suction them if you note that the amniotic fluid is stained with meconium. You want to make sure and suction the mouth and then both noses at the perineum before the chest is delivered, particularly in a patient who where you note that there's some meconium staining. You want to maintain an open airway, provide ventilations and chest compressions as necessary, and transport as soon as possible. There are some other things that occur that we'll talk about as far as emergencies in pregnancy. This would be prior to the birth of the baby. They include excessive pre-birth bleeding, ectopic pregnancies, seizures related to preeclampsia and eclampsia, miscarriage or abortion, trauma in pregnancy, stillbirths, and cardiac arrest in a woman. Now, excessive pre-birth bleeding, the main sign is unusually profuse bleeding. Abdominal pain may or may not be felt. You want to assess for signs of shock to determine whether or not the bleeding is significant. Give them high concentrations of oxygen. Place a sanitary napkin over the vagina. We're not going to pack anything in there. And if the mother does pass any tissue with that hemorrhage, you want to make sure that you collect that as well, because they could be products of conception. Be alert for acute abdominal pain in a patient who has an ectopic pregnancy. The pain can be referred to the shoulder with an ectopic pregnancy, so they may just have some shoulder pain. When we start doing assessments of female patients, particularly in childbearing years, if they're having any of that shoulder pain, if they're having any sort of acute abdominal pain, you want to incorporate those questions that address the possibility of being pregnant and whether or not she's having any vaginal bleeding. Assess the mother for a rapid and weak pulse, low blood pressure, and the mother may not know she's pregnant, but may have a history of an absent menstrual period. Perhaps she's missed her period or hasn't had a period for the last 3 to 4 months. Seizures can occur in pregnancy as a result of existing preeclampsia, which is a medical emergency that occurs in pregnancy. The patient becomes extremely hypertensive and seizes. They also get an excess weight gain because they retain lots and lots of fluid when they're preeclamptic. The mother, you'll note, will have excessive swelling to the face, the ankles, the hands, and the feet. The mother will have an altered mental status, a headache, or other stroke-like symptoms. Blood pressure will be really high, and she will seize. Miscarriage and abortion do occur. They can be spontaneous or induced. Spontaneous miscarriages or spontaneous abortions can occur if the pregnancy is not meant to be carried to term. The mother will have cramping, abdominal pains, bleeding, ranging anywhere from moderate to severe. She may have a noticeable discharge of tissue that may be even identifiable as a fetus. Trauma in pregnancy, the patient's pulse is typically going to be 10 to 15 beats per minute faster than a non-pregnant woman. So, one of the main compensatory mechanisms with blood loss and trauma is an increase in heart rate. Well, their heart rate's going to be up a little bit anyway. Again, they can have a lot of blood loss, 30 to 35% of their own blood volume lost before you start to see any signs and symptoms, particularly in that third trimester. Ask the patient if she's received any blows to the abdomen. Stillbirths, we don't resuscitate a stillbirth if it is obvious the baby died sometime before birth. But if the baby died perhaps within 24 hours of birth and looks well, is just in full cardiac arrest, we're going to begin resuscitation as we would any patient. get life support going, high quality chest compressions, oxygenation, and paramedic assist. Provide emotional support to the family. And there are certainly situations where mothers may carry their baby to term, know that the baby died at some point in time, and may have to go through the entire labor process in order to expel the baby, knowing all along that she's going to deliver a deceased baby. So it can be an extremely emotional time for family. Cardiac arrest of pregnant women does occur, and the rule of thumb is that if we're going to save the baby, we have to save the mother. So we're going to begin CPR immediately. But remember, particularly like in the third trimester, if the mother's got that big old belly and we lay her flat on her back to do the CPR, we're going to put some pressure on that superior vena cava and cut the blood supply off, lowering the blood pressure. So you're going to need to displace the uterus if the mother is more than 20 weeks pregnant. You can put your hands 1 to 2 inches higher on the sternum when doing chest compressions to make up for the shifting of the heart by the large uterus. Displacing the uterus is where you have one of your partners grab the pregnant abdomen and pull it to the left, lifting the uterus off the superior vena cava. So we're going to displace the uterus. We're going to slide our hands up a little bit, but we're going to push hard and we're going to push fast. And we're going to do CPR until an emergency C-section can be performed, or you're relieved by paramedics or in the emergency department. Now, as far as some gynecological emergencies, we'll look at things like vaginal bleeding, which is may or may not have anything to do with pregnancy. So vaginal bleeding is like bleeding from anywhere else. It's bleeding that you can see. And so if it's heavy, you're going to have to treat it as potentially life-threatening. You want to check for associated abdominal pain that goes along with this, and monitor the patient for hypovolemic shock. As we've talked, we're not going to pack the vagina with anything. We're just going to place an ABD pad or a feminine napkin at the vagina. Trauma to the external genitalia can occur. You can look for trauma to the genitalia, particularly if sexual assault has occurred, or the mother indicates that she's had some traumatic injury to that area. Remember that there's quite a bit of soft tissue there. It is quite vascular during pregnancy, and soft tissue trauma, there can be some significant blood loss from the external genitalia. And again, we would treat that as we would any vaginal bleeding with an ABD pad on the vaginal wall, or on the vaginal opening, or a feminine napkin. Sexual assault can occur in pregnant women. In fact, it occurs far too frequently than we'd like to believe, as well as not only sexual assault, but physical abuse or domestic violence occurs again quite frequently. During a sexual assault or during a domestic violence case, upon your arrival, you're going to treat that patient just like you would any other patient, looking for immediate life threats, making sure the scene is safe, approaching the patient, identifying yourself, assessing the airway, the breathing, the circulation. If there has been a sexual assault or domestic violence, you're in a crime scene, and so you have to be very careful not to disturb any potential evidence. You would only examine the vagina if the mother had complained of, or if the woman had complained of severe hemorrhage being present. If she's not bleeding severely, then there may not be a need to examine the genitals at all. Because it's a sexual assault, the presence of semen in the vagina may be there, pubic hairs from the assaulter may be there. So it's important that you encourage them not to bathe, not to pee, not to cleanse their wounds or douche. So they can be examined and samples can be taken in the emergency department. Sexual abuse is not a mandatory report or crime in the sense of child abuse or domestic assault. Sexual abuse is a flat out crime. And it is something that you would call law enforcement on if they've not been called already. Rape, that's a crime. That's not a mandatory reporter thing. That's a crime, and you would report that. Whereas something like the presence of drugs, although the drugs may be illegal, that is not something that you would report. But crimes like abuse and sexual abuse and domestic violence all need to be reported to the law enforcement. Okay? All right. So that ends our discussion of obstetrics and gynecologic emergencies. If you've got any questions, you know how to get a hold of me. So I'll talk to you soon.